His name was Oscar Mayer. An adorable animal. He was being raised to be a show pig. But unfortunately, he was also likely host of a bacteria called E. coli 0157, a bacteria that caused a severe infection in his owner. So severe that his owner, an 8-year-old boy, landed in my pediatric intensive care unit. The infection ravaged his small body. His lungs filled with fluid, and we needed to put him on a machine for him to breathe. His kidneys failed, and he needed dialysis to clean his blood. We weren't sure if he was going to live or die. His parents were amazing. Always by his side, hoping for the best, vigilant, never leaving. Unfortunately, it was planting season, and while they were there with him, the family farm suffered. After a couple weeks, he started to turn around and started to get better. And around the same time, the medical bills started to show up. To witness the burden of the finances on top of all the stresses of having your child in the ICU was almost unbearable to see. I remember after a couple weeks of him getting better and the parents settling into the ICU routine, the dad started to ask questions. Every couple of days or so, he would go to the billing office, get a list of what we had spent, and he would bring that to morning rounds, the time of the day that we go over our plans of care. And there, he would ask questions. Tough questions. Questions that my medical training really didn't prepare me for. That lab you got, same lab you got yesterday, same lab you got the day before, completely the same. You doing anything differently with that? And Tylenol, why does it cost so much in the hospital? Can I just bring some from home? His father was so polite, but you could see that the burden was on him. And truth be told, my answers were rarely sufficient. Why do we get that lab? Well, it's our routine. And true, we actually didn't do anything different, but it's just kind of what we do. Tylenol, I guess that's the hospital price? And no, you can't bring anything from home in. It's very important for me to emphasize this key point. At no point in his care do we make a medical decision based on cost. At no point do we discuss costs with the family when discussing therapies or treatment plans. We just did what was right. We did what was necessary. After all, his life was in the balance. There is no cost to that. Story ends well. He recovered, went home to his farm. And yet, years later, I reflect back to those weeks and months that he was in the hospital, and I think to myself, in the process of saving his life, did we bankrupt the family? And this is an extreme example of healthcare costs in today's society. If you ask anybody in a life or death situation, they'll likely say that cost is of no concern. But the reality of healthcare is it's rarely life or death. More often than not, it's the mundane, the routine, the common illnesses. Before talking about healthcare value, I think it's important to talk a little bit about healthcare costs and about healthcare costs here in the US. Costs here in the US are extraordinarily high, and it doesn't necessarily buy the health we think it does. In 2018, the US spent $3.6 trillion on healthcare. Despite spending over $30,000 per household annually, the US ranked lowest in life expectancy and the highest in chronic disease burden of major high-income countries such as Canada, United Kingdom, and Australia. What is even more worrisome for me is the fact that 10% of this spend comes from out-of-pocket spend, meaning 10% of the spend comes out of your pocket after insurance pays. For an average family with insurance, this could amount up to $3,000 annually. This kind of spend is what creates the health that we have here in the US. A recent study of ICU patients discharged with respiratory distress noted that 2/3 reported a financial burden after discharge. Not surprisingly, 2/3 of bankruptcies in the US are medically related. I think it's worth emphasizing that again. 2 out of every 3 bankruptcies in the US are related to the high cost of medical care. What we know from research is that 20% of a community health is dependent on clinical care, that $3.6 trillion I'm rapidly spending for you. 80%, however, are based on socioeconomic factors. Same factors that are completely devastated by financial burden. I've been in healthcare for 20 years now. I know I look young. And in that time, I've worked in almost every aspect of healthcare. I've worked as a management consultant. I worked as an operational leader, a strategist. I worked in senior healthcare administration. I worked for a startup as a clinical advisor. I worked in academia, in health services research, and teaching medical students. But the role that's most near and dear to my heart is I've been a clinician for my patients. Throughout this time, I've seen all aspects of healthcare, from payment to delivery to innovation, and this is what I know. The US healthcare system right now, as it stands, is still predominantly dependent on a fee-for-service infrastructure. So what that means is anything that I do for you and taking care of you, the more I do that service, the more I get paid. If I ask you to come to clinic every single day for a month, I get paid for every single visit you show up for. Every dollar that is spent within the healthcare industry is revenue for someone else in the healthcare space. This is a perverse incentive. Value is actually quite different from cost that we've been talking about. Cost is part of that value equation. Value takes cost into consideration. If I told you that there's a new drug on the market and the drug's 100% better than the existing drug and costs $10 more, most of us would say that's a high value medication. If the same medicine is only 1% better, 2% better, 5% better, and costs $10,000 more, you would argue that that may be a low value medication. Value takes cost into consideration as we select our path toward health. Our current healthcare system is not dependent on value. Instead, it is care regardless of cost. Now, providers want to do the right things. We want to take care of our patients to the best of our ability. If there's a therapy out there that is better than what we are currently doing, we want to try that therapy. If there's a medication out there that is more effective than what you're currently getting, most providers would prescribe that medicine, often without consideration of cost. But let me ask you this. If you needed to pick a medication to control hypertension or high blood pressure, which one of the following would you pick? The first medication is extremely effective, brand new, name branded, taken once a day, no side effects, costs $500 a month. The second medication is a generic, years in the making, battle tested. You have to take it twice a day though, and occasionally will give you nausea, but most people tolerate it okay. It's $10 a month. What if there's a third medication you have to take 3 times a day? This medication, strangely enough, will give you a rash. Looks kind of weird, but that's about it. This medication only costs $1 a month. Which one would you pick? You're probably doing some calculation in your head. What is it worth to you to take a medicine 3 times a day versus 2 times a day versus 1 time a day? What is it worth to you to have a little bit of nausea? What is it worth to you to have an unsightly rash? And you're coming up with the dollar amount in your head. And likely, the dollar amount varies across the audience. But in healthcare, we're not given the ability to balance the cost to the benefit. We're not given the ability to determine that value equation for us. Instead, that calculation is done by the provider, and patients get a binary choice. The providers will think, well, what is it that Mr. Smith would want? Obviously, he would like the very best. He wouldn't want to take a medicine more than once a day, and he clearly wouldn't want a rash, and he clearly wouldn't want nausea. So Mr. Smith leaves the clinic with a $500 a month medication, having never discussed the fact that there are other medications possible. What providers lose sight of in the process of finding the best for their patients is that cost matters to health. almost like a side effect. And in this case, the side effect is medication adherence. We know from an adult study of cardiovascular patients that 1 in 8 adult cardiovascular patients actually reported medication non-adherence due to cost. What's even more worrisome is that often people avoid care because of cost. A survey of Americans revealed that half of Americans at some point in their lives avoided care because of a presumption of cost. By trying to do the best that we can for patients in avoiding the discussion on cost, we inadvertently, as providers, may have created poor health for our patients and communities. Despite lots of research demonstrating that value-based care improves outcome and decreases costs, despite multiple value-based initiatives that are across the US trying to replace the fee-for-service infrastructure, the adoption of value-based care has been very limited. And one could be very cynical and say, well, payers, providers, other people in the ecosystem, they're going to lose income, so there's no way they're going to adopt this. One could be very cynical and say that the whole system needs to be chucked before something like this can ever happen. And ultimately, aspects of both are likely true. The relationship between payer, provider, patients, the healthcare ecosystem, all that will likely have to change in order to pursue value. The way that providers think about what they do directed toward health as opposed to healthcare services will also have to change under value. But I remain optimistic. I believe we could do this. And I believe that because it's the right thing. For what we spend in the US, we should have the best health in the world. We all want the highest amount of value in what we spend in healthcare. So how do we get there? I like to propose a simple first step. I propose that there needs to be a transfer of power from providers to patients. That patients not only get education, advice, and counseling, but they also get agency in deciding what it means to them to have a value-based care. Lack of agency, however, happens even when knowledge exists. Thing is, earlier this year, I was a patient. I had a relatively routine procedure, same-day outpatient surgical procedure for an inguinal hernia repair. The repair went amazing. It was a great day, went in, did my surgery, left. Pain was well managed, I recovered quickly. About a month later, I received my bill. The thing is, even as a provider, once I became a patient, I lost agency. And this is what I discovered in my bill. When you first go in, obviously you're going to have surgery, you need an IV, they put an IV in. Before the IV start, they give you a little lidocaine under the skin to numb that surface so that when the IV goes in, it doesn't hurt as much. It's pretty common practice. What I didn't realize was that lidocaine solution cost $75. To manage surgical pain, one of the things that I was given was intravenous Tylenol. One dose, $550. To manage localized surgical pain, my provider injected one of the newer local anesthetic into that area so that I could recover quicker. That injection, $2,650. Now, it's very, very important that I say the next part. I was 100% happy with my operation. It was great. I recovered nicely. My pain was manageable. It was great. But if asked, I likely would have refused the lidocaine if I knew it was $75. If asked, I likely would have just taken a dose of Tylenol at home for $1 as opposed to $550 IV. If asked, I may have pursued what kind of generic options I had for my local pain injection versus the brand name. What's the cost difference? What's the benefit difference? In every one of these examples, what I would be selecting is greater pain at lower cost. But just like you all did a little bit earlier, in our minds, we balance the cost and benefit, especially since none of these medications were life or death. If given a choice, would I have refused some of these medications, knowing that my out-of-pocket expense for this one-day procedure was $4,000? Absolutely. But I was not given choice. I was not given agency. What I was given was the best care possible without consideration of cost. I believe this is how value starts. Value starts by shifting that decision from the provider to the patient through education, through advice, through counseling, but ultimately through giving agency. And this won't be easy. Providers have to give up power, and patients have to ask for agency. I think back to my ICU patient getting better outside of the life and death situation, and I think, would I have given the family agency to select a path of greater pain for lower cost? I think back to myself as a patient in the operating room or about to go in for a routine procedure, non-life-threatening. Would I have asked for agency to select a path of greater pain and lower cost? More importantly, should I have asked? The next time you see your doctor, will you ask?